Stable podcast. I'm Danielle Kurzweil. I'm honored to join Alex Virches as co-host for this podcast, an important resource for therapists interested in growing their understanding of and ability to treat CPTSD and dissociative disorders. I've benefited gratefully from this podcast, being able to join this discussion rather than just passively learning through books and workshops, interacting with the information, asking questions, sharing our own real-time experiences, and creating community to pool knowledge. Like with our guest today, Kathy Steele. Kathy has contributed substantially to the work of improving therapist competency and providing effective trauma treatment, which you can read about in her website that's linked below. Today, we'll be discussing her work, which builds upon the work of Paul Gilbert and Giovanni Liotti to create clear and practical guidelines for therapists and utilizing a collaborative treatment model alongside their clients. Kathy is compassionate, impressively clear about very difficult topics, and brings to us immediately actionable and practical tips for connecting compassionately with our clients and ourselves as we do this highly challenging work. Enjoy. I was wondering if you could also give our listeners an overview of this collaborative model of therapeutic alliance that you talk about.
Right.
Relationship
Right.
between the therapist and their client.
Right. And I came upon this just through my own struggles as a therapist to help that subset of clients. It's not every client, but a small subset of clients that really struggled with dependency. It's like they needed the therapist all the time. And sometimes, the more available the therapist became, the more dysregulated the client became and just needed the therapist more and more. And so it was a vicious cycle. So that's what got me interested in what are we trying to do in creating attachment with clients and what can go wrong with that. And there's lots of things that could go wrong, but I want to focus on this particular thing because I think it's something that many therapists struggle with. Because by our nature, we are helpers. And by our nature, we respond with compassion and sometimes with urgency when somebody's in distress. And so, how to manage something that's very natural for us, but yet not get into a role where there's so much dependency on the therapist for the client that the client is becoming dysregulated. And the reason that more extreme dependency is not good, well, there are many reasons, but one of them is because in trauma, a client not only wants to be connected, but also needs to defend against relationship because relationship was what was traumatic for the client. And so when we're just paying attention to the needs of the client to connect, we're not always paying attention to the needs of the client to protect. Right? And the general thinking has been, well, if they can connect enough, this need for defense will gradually go down. But that often doesn't happen because there is often dissociation between the part of the self that's trying to connect and the part of the self that's going, oh no, that's too dangerous. Right. And so it's very important, I think, for the therapist to modulate the intensity of the relationship as best we can. And we do that through a kind of collaborative model. Now, that is not my own work. That work comes from several people in the field. The two that come to mind are Paul Gilbert, who wrote a lot about compassion-focused therapy, and Giovanni Liotti, who was an Italian psychologist and researcher, psychiatrist, both of them did a lot of work on the idea that in addition to attachment, there are other ways to connect that are built in for us. They're evolutionary prepared, right? And so, for example, for parents, there is this intuitive sense of caring for infants. We may not know exactly what to do, but we've got the instinct to care for, young children and infants in the same way that animals have that instinct. So this idea of caretaking is built in, and that's a way of connecting, but it's not about really attachment. It's about kind of rescue and caregiving. And there are other ways, like you can connect relationally through playfulness or through sexuality, and or through competition where, you're sort of judging, am I better than or less than everybody else, kind of putting yourself on a ladder. Mm-hmm. And all of those are built-in evolutionary prepared ways of organizing ourselves in relationships and in groups. And when traumatized clients have difficulty with attachment, when attachment doesn't work for them because it's dangerous, they may move to some of these other strategies. And one of the strategies that I hope that therapists can use is a collaborative strategy. And that strategy is about basic understanding of each other. Now, we think about understanding each other and sharing and working on goals. We can think of, well, a team at work collaborates on a goal, right? But there's a lot of other things that are going on besides explicitly cognitively saying we have this goal in mind that we're working toward. Collaboration at its most basic level is about, do I feel safe with you or not? Right? Because if I don't feel safe, I can't collaborate. Mm-hmm. And so we could think about what Stephen Porges talks about with the polyvagal theory and his idea of activating the ventral vagal system as being important in collaboration, because collaboration does activate the ventral vagal system, just like attachment does. And so if we think about collaboration, again, it's not only explicit, let's work on these therapeutic goals together, but it's about the felt sense of, do I get you? Do I understand you? And do you get me? And on that nonverbal level. And then we build the more explicit, let's together work in therapy based on that. The reason we want to use collaboration is because the client's attachment system is really overactivated in some way, whether that is through desperately seeking attachment or whether that is sort of desperately avoiding attachment. Clients get triggered when their attachment system is activated. So the idea is to try not to further activate the client's attachment system because it's really dysregulated already, but to use the collaborative approach to kind of calm it down a little bit, right? And I don't know if this is super different than the way we really approach attachment with a lot of clients. But I think we have to really understand when we're thinking about attachment, what is the goal of attachment? The goal of attachment is to have a felt sense of security so that I can come and go, whether my attachment figure is in front of me or away on a trip, or even, let's say in the case of my grandmother, who I was very close to, she's been dead for 20, 30 years, a long time, but I still hold her, right? I still have that figure internally. And so the idea is not to have the therapist there literally all the time, but to be able to take that representation in.
No, definitely.
And a
I
lot of
that I had a felt sense of my own grandma. Hmm.
That's right. That's right. Many of us have a felt sense of lots of other people, right? And sometimes we have a felt sense that's really bad, and that's difficult, right? But the felt sense of a positive enough figure is what secure attachment is really about. And sometimes we get confused. We think, well, I need to be available all the time. Call me when you need me, right? That's not really how secure attachment works. Secure attachment is saying, I'll be here when I say I'll be here. So it's consistent, it's predictable, and it helps the client. Let's together, here's the collaborative model. Let's together figure out what makes it so hard for you when I'm not here. And let's help you build some skills around that. So that's a beginning structure. And then my guess is you have some questions about that.
I do. I do. I was wondering, what does consultation with therapists around this issue look like? I know that you work with therapists directly and
Mhm,
help them with this. And
mhm,
for therapists out there who are looking for this kind of guidance, also other consultants who might want to
mhm.
support in this way.
Right.
Um,
Mm,
what are some of those elements? What are some of those conversations that come up, some of the typical conversations? And yeah, and
yeah.
I'm also thinking about those therapists who don't have access to consultation to give a tidbit
Right.
of things that they can
Yeah.
do on their own.
Yeah. Yeah. Well, I think that, therapists come in with this issue and they feel distressed. They feel guilty because they don't think they're giving enough, or they feel exhausted because they feel like I'm giving all I can give and the client still isn't getting better. And so therapists become distressed, and they may feel urgent. I've got to do something. And I think when those three things, one of those three things happens, that it's a flag, it's a red flag for me to say, ooh, I'm getting activated in my caretaking system, right? So it's a matter of really learning to stop and reflect. Where am I? Am I feeling burnt out? Well, maybe I'm giving too much. Or maybe I'm giving too much of one thing and not enough of another. Because constant availability, or relatively constant, is not helpful. And that's the thing. If it were helpful, maybe we could go with it and tolerate it and work with it a bit. But in general, it actually creates this, what John Bowlby called insecure dependency, where any sign that the therapist is going to go away or not be available, the client gets more and more panicked, right? And so it doesn't calm it down, it actually activates it. So when I feel the urge to caretake, to rescue, to be more available than I'm available for other clients, when my family might complain, you're never here, you're always on the phone with a client, that client, sometimes even the family is aware. When you feel when I feel burnt out, like I don't want to do this work anymore, it's not enjoyable. And sometimes when I feel trapped, like I can't stop what I'm doing because I think the client needs it, but I can't tolerate continuing to do it. Right. So you get this trapped sort of double bind. I think those are the things to look out for.
Are there different sensations when it's the other sort of side of that coin, when someone might be more rejecting or avoidant or
You mean
pushing
the
the
therapist or the client?
client?
The client. Yeah. I mean,
So it's
that's
sort of
the
the
opposite.
feels like the opposite of the pulling in.
It
but
is.
more of that, I might show up to every session, but you can't possibly help me.
That's right. That is a different issue. But again, collaboration is important because if somebody comes in and says, I'm desperate, I'm suicidal, but nothing has ever helped me, and I don't think you can help me, what happens in the therapist? The therapist thinks, I'm a I'm a trauma therapist. I can help where nobody else has helped. So we
Mhm.
get a little
You're
narcissism
okay.
going. Yeah.
Mhm.
Or we get, if not narcissistic, we get our caretaking activated like, well, I'll work really, really hard and try to find a way. And so it becomes the therapist work rather than the client's work. So, what I might say to a client like that is, well, I can imagine that you don't think I can help you. I don't know if I can help you. But what's really important is that we find a way to work together toward your goals. So, tell me something about what you want to accomplish. And then I can get curious about what hasn't worked and why. And then I can figure out, is there an internal block to getting the work done, or what actually is happening there?
That's such wonderful language. I do something similar. My consultant, one of the first things that he recommended that I do when I started working with him was to keep a little notebook by the side of my table for things that went sideways in therapy.
Ah, yeah,
Just
great idea.
saying that was such like a flood of relief. Like, okay, things
Yes.
are supposed to go sideways. I'm supposed to make mistakes. Things are supposed to feel awkward. I'm supposed to get confused, lost.
Yeah.
Um,
I don't know what I'm doing half the time or where we're going. And I've been doing this work 40 years and I still don't know where we're going half the time. Right. And I think it's really important to take the pressure off about getting it right because it's about relationship. And relationship is, just being human. Of course, we want to do a good job. Of course, we do. That's not the question. But not to beat ourselves up when things go sideways because we can't be prepared for everything and we can't control the client's reactions. Sometimes we can't even control our own reactions. And it's really normal in a therapist.
You use a lot of really wonderful language, especially when you're talking about curiosity and getting curious with both with yourself, kind of on our own, or maybe as we're preparing
Mhm.
for a session and also in session with clients. Wondering, is that something in consultation that you even role play with therapists, or is that something that
Yeah,
I know that we can certainly over plan, and that's not helpful. It's not helpful to go into a session with a script. Some of
right.
that
Yeah.
language might not be accessible, especially since I think a lot of us have, sort of maybe not so helpful responses to the feeling of conflict, for example, or there
Mhm.
might be some automatic words that come out and we're like, well, that's not exactly how I meant to phrase it. But to have at the ready, because we've practiced it a bit, not because we know
Mhm.
exactly what we're going to say in this session, but to have some of those, and I mean, and I am thinking about some of the graphs and the tables that you have in this,
Yeah.
but I
Yeah.
wonder if there's a way, that therapists can practice that outside of session as well as in session, so we're not always sort of floundering.
Yeah, right. I mean, I think floundering is part of the process. And I think as you do therapy longer, you learn ways of saying things that are empathic, but perhaps also limit setting. Um,
Right.
Something like that.
That suit your
Um,
personality. Like you
yeah,
sound
that
like me
fits
when
for
you say it.
you.
I might be like me when you sound like me when I say it.
Yeah, yeah. You don't want to talk like Kathy Steele because it would come across as not genuine. You have to find your own way. But this idea of compassionate curiosity, I think, can really shape our language. Like being it's almost like rising above the situation and looking at it and go, oh, isn't that interesting? Rather than, oh my gosh, I'm so frustrated with this client. Like, oh, I wonder why that client is not able to take in anything positive today. Now, that's not what I would say to the client. But what I might say to the client is, I'm just noticing today, I'm really curious. It seems really hard to find a place that feels good for you. And that must be hard for you today. Can you talk about that a little bit? So you're coming at it. Can we be curious about that a little bit? And you're helping the client get a little distance from being stuck in it by going, oh, yeah, yeah. So the little bird's eye view comes in very, very handily in this way because it also helps move me out of whatever feeling I have, whether I'm bored or frustrated or whatever. It's like, oh, isn't it interesting? I'm bored. Why would I be bored with this client?
It's just, yeah, so you're really starting internally or pausing internally and having that,
Yeah,
and then
yeah.
formulating it into how you might explore that with compassion
Hmm.
and curiosity with the client. I find that sometimes, especially if I'm feeling nervous or my nervous system is activated, like you were saying before, sometimes we can't always be in control of our, how our brains or our nervous systems are responding. But the thing that I think of first might get stuck, and I know it's not the right. So then I might sort of
Hmm.
be quiet, and and kind of later then formulate and come back. And it seems like this
Yeah.
notion, a lot of these words come from kind of, parenting or reparenting, but I think that these
Right,
work
right,
in any kind of relationship, and I
right.
love your use of the word coach, guide, or mentor in the book.
Hmm.
We can use like the form of a repair, like
Hmm.
coming back, being able to step outside, and
Right,
maybe kind of do
right,
some of that work outside of session and then come back next time and
right,
go back and
right.
address, I was feeling or thinking.
That's right. I think we always have opportunities to come back to things. We often can't sort them in the moment. But that's what secure attachment is rupture, repair, rupture, repair. So being able to do that. And I think, with the collaborative model, the whole idea is to sometimes share with the client. It's like I'm really worried about your safety, and I don't really know where to go with that. Could we together think about that and find a way? Because you're saying you don't want me to hospitalize you. I don't want to hospitalize you either, but we're kind of stuck here because you have got to be safe. I can't work with you if you're not safe. I wouldn't say that to the client, but you can't work with a dead client for sure.
Mhm. Mhm.
So this idea of basically saying, I'm not sure where to go from here, and make that a model of that's okay that we don't know where we're going.
Mhm.
But then let's together get curious. So it's collaborative, let's together sort it out. What do you think? And the client says, I don't know. And I go, I don't know either, but that's a place that is familiar to us in therapy. So let's be together with our I don't knows and see where we go.
Yeah, I love that. That really helps answer actually one of my questions. I sort
Mm,
of had highlighted something that I had written down something that you had written in one of your books, that we are looking to activate the exploration system. And then,
yes.
as we did
Yeah.
that, I did, again, I had that felt sense
Yeah.
of wanting to go inside and answer the question as opposed to being reassured by you or taken in by you or
Right.
looking for the answers from you. It was, yeah,
Right.
that sense of, okay, we're together going to be putting our heads together.
Right. Right. And for example, with a client that you might want to reassure, a client that says, nobody likes me, I'm so unlovable. No, you're not. You're lovable. That's the first thing that wants to come out of my mouth. But it
Mhm.
doesn't do anything. The client just can't take it in. So what I might say is, oh gosh, that sounds so painful and lonely. And I'm kind of curious about something. What is it like for you to be with me in this moment when, I'm having the experience of finding you an interesting person? I don't even say likable because that's too intense, but I find you very interesting.
Mhm.
What is that like for you to hear that? And so it activates the client's curiosity, but it's not so much about like and love, which gets into all this attachment stuff.
Right, right.
But it also presents the client with the reality of you're with somebody who finds you interesting. What are you going to do with that? Which is really different from trying to reassure.
Yeah,
Mm,
absolutely. Absolutely. Yeah, it seems like it could be helpful to think about um, those questions of curiosity, going through and
mm,
thinking about the things that might, I mean,
mhm,
going through our past sessions, those
mhm,
inklings that we had, places where we got stuck,
mhm.
thinking about what was going on in our heads and then translating that in the way that you're
Yeah,
doing, in a
right.
way that feels like us, but also, yeah, it is expressing those feelings of curiosity. And then also, it sounds
Mhm,
like it's important to look for words or language that are intense. My daughter like,
mhm.
Mommy, you're over intensing me. It's like the over intensing feeling. And
Yeah,
and that's right. I think
yeah,
language is
yeah.
so important. Um,
Right. We're trying to modulate,
Modulate.
not too warm, not too cold, but just right for the client in the moment, which of course we're going to miss that mark a lot, aren't we?
Yeah, I'm gonna
But
kind of write
but
that
in
down in our
general,
notebooks.
yeah, and I think that idea of compassionate curiosity and collaboration, the three C's, right, is a wonderful way to be with clients without falling too much into rescue and caretaking, and without the client falling too much into over idealizing the therapist who's supposed to be the guru expert. I don't want to be that. I want to be human. Like, I don't know. I'm not certain. I don't have all the answers, and not in a way that is I don't know, frightening for the client, because I think we need to, of course, show that we have some competence, but I don't want to put myself on the ladder above the client. I know what you don't know. I know better than you. I'm gonna tell you. But rather, no, I don't know if this will work or not, but are you willing to try it?
Um, how much so yeah, another question of curiosity that I have, when you do treatment planning alongside a client in this collaborative model, do you ever share anything written with them? Or I mean, maybe this is kind of a client by client basis, but to help kind of organize like a map, because you are creating something together, but it might feel
Mhm,
more clear in the therapist's mind. This is one of the
mhm.
things that I think we can sort of hold with some confidence and some sturdiness, is that, of course, a very flexible map, but here, this is where we're
Yeah,
going. Is that something that you kind of coach folks in doing? I feel like a lot of us therapists learn a very robotic method of treatment planning that's kind of based on what insurance companies want and not necessarily something that's practical either for us or the client.
that's right.
I do think some clients might benefit from that.
Yeah, and the collaborative model really uses treatment planning as the source of what we're working on together.
Mhm.
And that should come from the client. Perhaps, of course, with input from the therapist. Like if the client says, I want to get rid of all my feelings, it's like, Oh, sorry, can't help with that one.
Mhm.
But sometimes the problem with treatment planning is it's either for the benefit of the insurance company or it's what the therapist thinks needs to happen. Like, oh, the client's got trauma, the client's got DID, let's do DID and trauma work. The client may be so avoidant that that is not their goal. And so I think it's very important to ask clients what they want to achieve and, to be more specific. Like lots of clients say, well, I want to feel less anxious or I want to feel better. Well, if you felt better, if you felt less anxious, what would be different in your life? Well, I'd be able to get up and out of bed and go to work in the morning. Okay, so that becomes a goal. So trying to make it specific. And then, of course, reducing anxiety or feeling better can take a long time and can be very complex with layers. But to talk with clients about where we are and where we're going. Another part of the collaborative model is to frequently, sometimes every session, check in with a client. How are you doing now? After we did that, we did some EMDR or whatever it was. How are you doing? How are all parts of you doing? Was any part not happy with that work? Right. And so we're course correcting in minute ways by getting constant feedback by the client, from the client. And then I do a sort of review depending on the client, every 3 months, every 6 months, every year. How do you think the last 3 months or 6 months has gone? What do you think we need to do differently? And so you're asking about writing it down. I don't necessarily write that down, but we certainly could. But the client is quite aware of what we're working on along with me. Like if we're working on affect tolerance, what does that mean? It means, being able to tolerate your anger instead of lashing out at your kids, for example. Being able to at least go and count to 10 in your own room and calm down a bit, or being able to tolerate a little bit of anxiety in session, that kind of thing. So I do explain a lot of it just in common language. I can be quite theoretical and up here, but with clients, I try just to explain it at a very human level.
No, I can too. And that was actually my last
Mhm.
question was, you know, I think I might overdo sometimes sharing the theoretical with clients. I do, I try to modulate and kind of share,
I love
on the
theory. It's
content.
so
I do too.
frustrating not to share it.
And I want to bring people in, and I sometimes
Yeah,
I convince myself that, well, that is being collaborative. I'm sort of onboarding them as a therapist. So I think
yeah.
sometimes that might actually be useful. But yeah,
Mhm.
but how do you modulate that? That might be that's sort of like a pretty heady and theoretical question, but as best you can, yeah,
Yeah.
how do you kind of pay attention to that tendency? I think it also can be kind of a safety. I don't know what to say here, so I'll go back to.
Yeah, a lot of us talk when we're anxious or we don't know where we're going. So sometimes I'll ask for feedback. Could you tell me, if you get that eyes glazing over feeling, because I don't want that between us.
Oh,
And
I love
sometimes,
that.
sometimes I don't
Love that.
know, and so would you just raise your hand and say, my eyes are glazing over? Um, right?
Okay,
And
great.
so you can
Depends on
approach
what's
it with
going on.
humor. You
Mhm.
can approach it with just beginning with, uh, trying to get a feel for where the client is intellectually, curiosity wise, and whether their curiosity about theory is going to be helpful or if it's an intellectual avoidance of the work, right? I
That's
think
right.
that's what we have to figure out.
Mhm.
And when I get into talking about it, is it my own avoidance that's getting activated there? Because I don't know what to do. Yeah.
Wonderful. Thank you so much for your time.
For
Incredibly
having me today. It's a
hopefully
pleasure.
folks who listen can really pull so much out of this
Yeah.
and use it immediately. It's very, very practical. If you enjoyed this conversation and you're a clinician treating complex trauma or a student learning how and would like to join this conversation, please sign up for a clinicians only discussion board. Email dissociativetable@gmail.com. Our intro and outro is by the band Cracked Machine, who generously donated rights to their music in support of global access to trauma therapy resources.